You take your medications faithfully, every morning, every evening, exactly as prescribed. Some of them you have been taking for years. You trust them because your doctor prescribed them, because the pharmacist filled them, because the label says they are safe when used as directed. And in most respects, for most people, that trust is entirely warranted. But here's the specific piece of information that most prescription conversations do not have time to include, and that most older adults have never been told in explicit enough terms to act on. A study published in JAMA Internal Medicine followed over 300,000 adults and found that cumulative use of anticholinergic medications, a class that includes some of the most widely prescribed and most widely purchased over-the-counter medications in the world, was associated with a 50% increased risk of developing dementia. Not a marginal elevation, 50%. And the risk increased directly with the duration of use and the number of anticholinergic medications taken simultaneously. The word rapid in this video's title refers to something specific, cognitive changes that occur faster than normal aging would predict, that are sometimes mistaken for early Alzheimer's, and that in some cases, when the causative medication is identified and addressed, are partially or fully reversible. That reversibility is what makes this conversation urgent, because a cognitive decline attributed to aging and left unexamined is a very different outcome from one identified, addressed, and in some cases, partially reversed. 9 of the most commonly prescribed and most commonly purchased over-the-counter medications in this country carry a documented cognitive risk in adults over 60 that most people taking them have never been told about. Today, that changes. And before we go one word further, please hear this clearly, and I will repeat it before every item on this list. Do not stop or change any medication based on this video. Speak with your doctor. Every item I name today requires that conversation, not a self-management decision made alone at the medicine cabinet. The American Geriatric Society publishes a document called the Beers Criteria, the gold standard reference for potentially inappropriate medication use in adults over 65. Updated regularly by panels of geriatric medicine experts and based on the most current published evidence. The Beers criteria explicitly flags anticholinergic medications as among the highest priority medications to review and deprescribe where alternatives exist in older adults. Understanding why requires understanding one specific piece of brain chemistry. Acetylcholine is the neurotransmitter the brain uses for memory formation, attention, learning, and cognitive processing. It is the same neurotransmitter that is depleted in Alzheimer's disease. The depletion of acetylcholine in the hippocampus and cortex is one of the defining biochemical features of Alzheimer's pathology. Anticholinergic medications work by blocking the receptors that acetylcholine binds to, and they block those receptors throughout the body, not selectively in the bladder or the gut or wherever their therapeutic target is. The brain's acetylcholine receptors are blocked alongside the target receptors. Think of it like a master key that opens every lock in a building when you only needed it to open one. The therapeutic door opens, but so do all the cognitive ones. In a young adult with abundant acetylcholine production and robust cognitive reserve, this blockade is temporary and mostly tolerated. In an older adult, the picture is categorically different. Acetylcholine-producing neurons in the basal forebrain, the brain's primary acetylcholine factory, naturally decline in number and productivity with age. The baseline acetylcholine reserve that anticholinergic medications are drawing down is already reduced. Every dose of an anticholinergic medication in an older adult is drawing against a diminished account. And the cumulative overdraft across multiple medications, across months and years of use, is what the JAMA Internal Medicine study measured as a 50% increase in dementia risk. The study also found a dose-response relationship. The more anticholinergic medications taken simultaneously, and the longer the duration of use, the steeper the risk elevation. This is what the American Geriatric Society means when it talks about anticholinergic burden. Not a single medication in isolation, but the total accumulated cognitive cost of a medication regimen when its anticholinergic components are added together. Here are the 9 medications. My name is Dr. Nicole Harper. Today, I am walking you through 9 medication categories with documented cognitive risk in older adults with a specific mechanism for each. The evidence behind the risk and the exact conversation to have with your doctor. Drop your city or country in the comments right now and tell me how many medications you take daily, prescription and over-the-counter combined. That number matters more than most people realize. Medication 1. Anticholinergic bladder medications. Oxybutynin, Detropan, Toltarine, Detrol, Solifenisonin, Vesicare. Prescribed for overactive bladder and urinary incontinence, genuinely distressing conditions that affect quality of life significantly. The therapeutic mechanism blocks muscarinic acetylcholine receptors in the bladder wall to reduce urgency and frequency. Think of acetylcholine signaling in the brain like a telephone exchange. Anticholinergic bladder medications do not block calls only to the bladder. They block calls throughout the entire exchange, including the memory and attention circuits that depend on acetylcholine to function. The JAMAMA Internal Medicine Study found these medications among the highest individual contributors to dementia risk in its cohort of over 300,000 adults. The research confirmed that even relatively short-term use, 3 months or more of daily exposure, began to register as measurable cognitive burden. Longer-term users showed the steepest risk elevation. Newer alternatives, specifically mirabegron Myrbetriq, which works through a beta-3 adenuric mechanism rather than anticholinergic blockade, provide comparable bladder symptom control without disrupting the brain's acetylcholine system. Conversation to have with your doctor. Is there a non-anticholinergic alternative for my bladder symptoms given my age and cognitive health? Medication 2. First-generation antihistamines. Dianhydramine, Benadryl, ZQuil, Tylenol PM, NyQuil PM, chlorphonamine, the most widely self-administered anticholinergic compound in the world. Available without prescription. Marketed as a sleep aid and allergy medication, consumed nightly by millions of older adults without any awareness of its cognitive profile. Dianhydramine is among the most powerfully anticholinergic compounds in common use and crosses the blood-brain barrier readily. The morning grogginess most people experience after taking it is the direct sensation of residual acetylcholine blockade in the brain. The cognition-impairing effect has a name, and it lasts longer than the sleep effect in older adults. The BMJ published a large prospective study confirming that regular dianhydramine use was associated with increased dementia risk, independent of other factors. Every PM formula medication, Tylenol PM, Advil PM, NyQuil PM, adds dianhydramine to its active ingredients. Read the label before assuming a familiar product is cognitively safe. Conversation to have. I have been using dianhydramine as a sleep aid. What are the safer alternatives for someone my age? Medication 3. Tricyclic antidepressants. Amitriptyline, elavorptyline, doxepin. Frequently prescribed in older adults not for depression, but for chronic pain, neuropathic pain, migraine prevention, and insomnia. Conditions for which their sedative and pain-modulating properties are useful, but whose anticholinergic side effect profile carries significant cognitive risk. Tricyclic antidepressants carry among the highest anticholinergic burden of any antidepressant class, and are listed on the Beers criteria as medications to avoid in older adults when alternatives exist. In adults already experiencing early cognitive changes, the anticholinergic and sedative effects can produce acute confusion episodes, sudden, significant cognitive deterioration that may be misdiagnosed as dementia progression rather than recognized as a medication effect. This misdiagnosis leads to additional medications being added rather than the causative one being reviewed, a cascade that compounds the original problem rather than resolving it. And that is one of the most preventable sequences in geriatric medicine. It is one of the most consequential and most preventable cascades in geriatric medicine. A medication side effect producing symptoms that trigger another medication which carries its own cognitive burden, compounding the original problem. Conversation to have. Given my age and the anticholinergic burden of tricyclic, is there a lower risk alternative for my specific condition? Medication for certain antipsychotics: quetiapine, Seroquel, olanzapine, Zyprexa, chloroprozine. Increasingly prescribed to older adults for insomnia, agitation, and anxiety. Off-label uses that carry a specific and serious cognitive warning. The prescribing conversation does not always deliver. Antipsychotics with significant anticholinergic and sedative profiles produce cognitive blunting, impaired attention, and slowed processing in older adults whose baseline cognitive reserve is already reduced. The FDA has issued a black box warning for antipsychotics in elderly patients with dementia-related psychosis, a documented increased mortality risk that reflects the broader physiological vulnerability of the older brain to these compounds. When prescribed for insomnia or anxiety, where the risk-benefit calculation is significantly less favorable than for psychosis, this warning applies with particular force. The sedative and cognitive blunting effects of these medications in older adults can also mask the early warning signs of genuine cognitive decline, delaying diagnosis and intervention at the stage when those interventions are most effective. The conversation to have. Given the FDA black box warning for older adults, what is my specific risk-benefit assessment for using this medication for sleep or anxiety? Medication 5, benzodiazepines, diazepam, Valium, lorazepam, Ativan, alprazolam, Xanax, temazepam. Among the most widely prescribed medications in the over 60 population for anxiety, insomnia, and muscle relaxation, and among the most consistently linked to cognitive impairment in the literature. Benzodiazepines enhance GABA, the brain's primary inhibitory neurotransmitter, producing sedation and anxiolysis by broadly suppressing neural activity. Think of this like turning down the dimmer switch on the entire brain's electrical system, rather than specifically targeting the anxiety circuit. The anxiety quiets, but so does the processing speed, the memory consolidation, and the attentional capacity that older adults are already working to protect. The anxiety quiets, but so does the processing speed, the memory consolidation, the attentional capacity that older adults are already working to maintain. In older adults, this neural suppression is less precisely targeted and more broadly inhibiting. A study published in BMJ found benzodiazepine use associated with an approximately 50% increased risk of Alzheimer's disease. The Beers criteria explicitly recommends avoiding benzodiazepines in older adults for insomnia and anxiety, given the availability of safer alternatives. Conversation to have. Given the published cognitive risk data for benzodiazepines in adults my age, can we discuss a tapering plan and safer alternatives? Medication 6, proton pump inhibitors, long-term use, omeprazole, Priloc, esomeprazole, Nexium, pantoprazole, Protonix. The cognitive risk mechanism here is different from anticholinergic blockade and less widely known. Gastric acid is essential for the absorption of vitamin B12. Long-term PPI use reduces gastric acid production, significantly impairing B12 absorption over time. B12 deficiency produces neurological symptoms, including memory impairment, cognitive slowing, and depression. Symptoms so similar to early dementia that B12 deficiency is one of the most common and most reversible causes of dementia-like presentations in older adults. It is also one of the most consistently missed because B12 is not routinely included in standard blood panels unless specifically requested. If you have been on a PPI for more than 12 months, there is a meaningful probability your B12 level has never been checked since starting it. Conversation to have. Has my B12 level been checked since I started this PPI? Do I still need it at the current dose? Additionally, emerging research has linked long-term PPI use to altered gut microbiome composition, reduced diversity of beneficial bacteria, and associated changes in neuroinflammatory markers. The gut-brain axis is an active area of dementia research, and proton pump inhibitors are among the most consistently identified pharmacological disruptors of gut microbiome diversity in older adults. Medication 7. Certain blood pressure medications, propranolol, atenolol, at higher doses, clonidine, methilopa. The majority of blood pressure medications do not carry significant cognitive risk. ACE inhibitors, ARBs, and most calcium channel blockers are generally cognitively well tolerated. The specific concern is with lipophilic beta blockers, particularly propranolol, which cross the blood-blood-brain barrier and produce CNS effects including cognitive slowing, depression, and memory impairment in older adults. Centrally acting antihypertensives like clonidine and methilopa produce sedation and cognitive blunting through direct CNS action and are listed on the Beers criteria as medications to avoid in older adults. This is not a reason to stop treating blood pressure. Well-managed blood pressure is itself one of the strongest modifiable protections against dementia and stroke. It is a reason to ask whether the specific agent carries avoidable central nervous system risk when alternatives with equivalent blood pressure control and lower CNS penetration are available. The blood pressure management goal and the cognitive protection goal are not in conflict. The medication choice between them sometimes is conversation to have. Does my specific blood pressure medication cross the blood-brain barrier? And is there an equivalent alternative with a lower CNS side effect profile? Medication 8. Certain muscle relaxants, cycloenzapine, Flexeril, Carisopro, Soma, methylarbamol, Robin, prescribed for muscular skeletal pain and back pain conditions, extremely common in the 60-plus population, making these among the most frequently encountered medications in this age group. Skeletal muscle relaxants produce their effects largely through central nervous system sedation rather than direct muscle action, meaning their therapeutic mechanism is broad neural suppression rather than targeted muscle relaxation. Cycloenzapine carries substantial anticholinergic burden and is explicitly listed on the Beers criteria as inappropriate for older adults. The cognitive effects include sedation and confusion, with the additional danger that sedation-related balance impairment increases fall risk, and falls in older adults carry a second chain of harm independent of the cognitive risk. Most guidelines recommend these medications for the shortest possible duration and at the lowest effective dose in adults over 60, with non-pharmacological alternatives, targeted physiotherapy, heat therapy, topical anti-inflammatories, and gentle progressive movement prioritized as first-line management before reaching for a muscle relaxant that will simultaneously relax the muscles and fog the brain. Conversation to have. Is there a non-pharmacological or lower anticholinergic alternative to this muscle relaxant given my age? Medication 9. Z-drug, sleep medications. Zolpem, Ambient, Zaloplan, Sonata, and Zapacone, Lunesta. The Z-drugs were developed as shorter-acting, supposedly safer alternatives to benzodiazepines for insomnia. In younger adults, the safety improvement is real. In older adults, the cognitive risk profile remains substantial, and the Beers criteria recommends avoiding them in this population. Zolpam has been associated with next-day cognitive impairment, retrograde amnesia, patients performing activities during the night they have no memory of, and increased fall risk from nocturnal confusion. The FDA lowered the recommended Zolpam dose specifically for women and older adults based on its extended duration of action and disproportionate cognitive effects in these populations. Long-term Z-drug use has been linked in published research to increased dementia risk. Cognitive behavioral therapy for insomnia, CBTI, is the evidence-based first-line treatment for chronic insomnia and has been shown in multiple trials to produce superior long-term outcomes to sleep medications without any cognitive risk. Conversation to have. Given FDA guidance on Zolpidem in older adults, can we explore CBTI or lower-risk pharmacological alternatives? 5 rules for using this information safely as the basis for an informed medical conversation, not a self-management decision. Rule 1. Do not stop any medication on this list without speaking to your doctor first. Every medication named today has a legitimate clinical use. Some of the conditions they treat, anxiety, insomnia, hypertension, bladder urgency, carry their own serious health risks when untreated. The cognitive risk does not automatically outweigh the clinical benefit. That calculation is individual, clinical, and requires the full picture of health history, comorbidities, and available alternatives that only your doctor has. This video provides the language for the conversation. It is not a replacement for it. Rule 2. Ask for a formal medication review that includes your total anticholinergic burden score. Anticholinergic burden is a calculable number. The cumulative anticholinergic load of all medications taken simultaneously, scored using validated tools like the Anticholinergic Cognitive Burden Scale. A total score of 3 or above is associated with significantly increased cognitive impairment risk. In published research, many older adults taking multiple medications with individually modest scores are unknowingly carrying a high total burden. Ask your doctor or pharmacist specifically, what is my total anticholinergic burden score across all my current medications? That question alone may be the most valuable thing this video prompts you to ask. In the next video I am publishing, I am covering the 5 supplements most commonly taken by adults over 60 that research increasingly questions, and at least 2 of them are ones most people assume are always beneficial. You will want to see that before your next pharmacy visit. This is Dr. Nicole Harper. Take care of yourself and take care of your brain. I will see you in the next.